Well, thanks very much, Paul, and thanks very much for the invitation to speak today. I'm going to go into some of the nuts and bolts of what Paul just talked about and give you some detail there. But before I did that, I just wanted to comment that when you talk about collaboration, I think the process that Paul just described with ASTO, working with multiple states with a very common purpose. We had, as he mentioned in his talk, numerous teleconferences with all the states involved in full-day meetings with teleconferences with all our partners at each state level. I would really hold this out as a model for how to do collaborative work across the country. Typically what CDC will do is fund individual states with a set of similar goals and objectives, and the states work in that direction and may go to a national meeting or two and talk about what they're doing. But this process, I think, was unique in my experience, and I think we found it extremely valuable. As Paul said, we were asked to make major changes in a clinical outcome within less than a year's period of time, which is unthinkable even in public health programs, much less in clinical medicine. So this process that Paul just described with ASTO coordinating, providing technical assistance about PDSA cycles and how to do QI and other things like that really got a group of states working together, and the outcomes, I think, speak for themselves. So I would just hold this out as a lesson from the Million Hearts collaborative approach as to how to do collaborative efforts among states. So I'll talk a little bit about our collaborative partners in New York. We picked a rural, an urban, and a suburban community health center to work with, and the corresponding county health departments. Among our partners was a group called the Health Center Network of New York, which is a group of all the federally qualified and lookalike health centers in New York that use a single EHR package called eClinicalWorks, which people may have heard of. So there's actually a group of them, the community health centers, that work together around the data, and this was one of the keys, I think, to the success in our project, is that all of our clinical sites had the same software, not as Paul indicated, that it could actually function as a hypertension registry, and I think that's one of the lessons and where we need to move next, but we were able to generate similar metrics from each of the sites using that similar data package. We used our state's quality improvement organization, IPRO, to do some of data analysis. So we had several levels. We worked at the clinic level, but we also looked at Medicaid data at a statewide level to see whether we could use it as a surveillance tool for hypertension. We engaged also in one of the areas in the Albany area, our regional health information organization, RIO, a group called HICSNY, which pulled together numerous practices and some of the hospitals in the area, and we looked at how we could use that to do hypertension surveillance at a community level. So we had a number of different aspects. Key to this was the involvement of our county health departments in these areas. In New York, our county health departments don't really provide clinical primary care services anymore. We have gone to managed care in a big way over the last couple decades. Our Medicaid program is phasing out fee-for-service, and so our county health departments have really had to reinvent themselves. They used to provide clinical services and do a lot of run home health services, and they've really gotten out of that business and are now more sort of pure public health agencies, being the coordinating function, the planning function for health within their communities. So they got very much involved with this. And we did tap into other groups, and as Paul mentioned, it's amazing where you can find partners out there if you start to look, and we probably haven't exhausted all the potential partners, but we tapped into AmeriCorps workers in some areas, and the Cornell Cooperative Extension, which is a group of agencies across New York which provide education and other services at the local level. So we did try to reach out. We had the American Heart Association and the Health Plan Association as well involved at the statewide level. So a big partnership to try and manage, and we spent quite a bit of effort with that, with the support, as Paul mentioned, of our state health commissioner. So our aim in New York was to produce a 10% improvement in 1 year in hypertension control. We did use the NQF-18 measure. And we also focused on some antecedent measures of undiagnosed hypertension, and I'll show you some of the data that we were able to come up with. We did use an IHI-type model for implementing system changes and then using PDSA cycles to try and improve, and this is mostly happening at the clinic level using data to try and see what you can do to improve things. We did, a key to any kind of effort like this is to establish clinical treatment protocols. CDC has some for hypertension. There are others. Each of the clinics adopted a protocol, so that's sort of the first step, is to really do sort of a checklist, a type approach to providing care, because the steps with each patient are the same and you don't want to forget a step along the way. The FQHCs did implement changes in how they processed, even to the extent of changing the exam room around so that it would be easier to get blood pressure without having to have the patient move or stretch. So lots of sort of down in the nitty-gritty things like that were worked on. And we did include also a home blood pressure monitoring piece of this, where patients received automated blood pressure monitors to take home, and we worked with the AmeriCorps collaborators and the county health departments to train them and work with them in the home with community health workers out of the county health department. So just lots of different programmatic pieces to this effort that were underway. And then the other big piece of this is the data piece. You can have a great protocol, but if you're not measuring what you're doing, you don't know where you are or where you've been or where you're going. So here I think, as Paul alluded to, there are still major challenges with making electronic health records actually function in this way. So we got into some of that. We found that the software package these FQHCs were using really couldn't function itself easily as a registry. So we worked with the healthcare center group to pull data extracts. That's because all these health centers were using the same software. They had a common warehouse, and so the HICNI group was able to essentially provide data back to the clinics, not in real time, but a summary of that functioned as a registry function for them. I think in the future, obviously, you'd want the EHR to be able to do that while the clinician is there, with the patient. But we worked around that while that's being developed. We worked around that through this kind of workaround mechanism. We decided that we wanted to look at undiagnosed hypertension, and there isn't an NQF measure for that, I don't think. So we actually developed a measure and piloted it, and it essentially was elevated blood pressure on 2 different occasions within a year without a diagnosis in the diagnosis list of hypertension. So we worked through how you would identify that cohort of patients through the electronic health record, and we focused on improving. One of the things we did was focus on improving that the diagnosis of hypertension in those patients. We also focused a bit on hypertension medication adherence. And here we have this was in the Medicaid population primarily. We have a data mart in New York, and it's because it takes a while to actually get data use agreements in place so that Medicaid can feed data right back to the clinic. We didn't take that approach. We used the data mart to try and identify medication adherence rates in the different clinics with mixed success, and I think that's another area where we still are in process and need to improve how we do that, ideally through a direct connection between the Medicaid program back to the practitioners. We looked at a couple of adherence measures. One is a CDC measure on the proportion of days covered, and a second measure, which I think we thought was important, which we looked at, was what we called primary non-adherence, which, in other words, you give the patient a prescription and they don't fill it in the first instance. So that's a failed attempt to try and get somebody on blood pressure medicine, but the physician may not know that until the next time they see that patient in the clinic, that the prescription actually didn't get filled. So we tried to approach that. I think we're still working on the best way to do that. And then, as I say, we looked at hypertension surveillance at a population level in one county where there was a regional health information organization which tied in many but not all of the clinicians and hospitals and clinics in the community, so we could actually get a close to a population look. And we looked at overall prevalence, the measures of hypertension control and undiagnosed hypertension in a community. That was also a mixed effort, and a lot more work there needs to be done, particularly in getting the data coming into these regional organizations in a way that it can be analyzed in a similar function. I mean, the value of a RIO is that it can pull data from different electronic health records, and you don't have to have everybody using the same record. On the other hand, the data comes in different formats, and some of it can and cannot be used for something as specific as this. So that's another of the lessons learned that I can talk more about it later. So let me just show a little bit of data from our project. The first thing we looked at was the prevalence of hypertension, and you can see in our 3 health centers here, we had a bit of range from 29 to 40% baseline for the prevalence of hypertension. New York, I think, is number 4 in the country in hypertension prevalence according to BRFS. So this is a major issue for us in our cardiovascular disease prevention world. Whether these differences reflect differences in how the different centers are measuring blood pressure and detecting hypertension, or whether they reflect I think it's probably more the underlying populations. The center with the highest baseline prevalence had a predominantly African American population. The other 2, one was predominantly white and the other predominantly Hispanic. So that baseline may reflect actually the underlying rates of hypertension in the population served. And then within a year, we had increased the prevalence a little bit, so our goal was not to increase hypertension prevalence, but to get a real measure of what it was in these communities. So I think we're a little bit more comfortable that in 2 communities we didn't increase it that much, so they must have been doing a reasonable job. In the one community, it did increase by about 11%. So clearly, getting your data right in the beginning to know who has hypertension is the first step to any kind of a approach like this. And then looking at the undiagnosed hypertension, the rates were actually lower, I think, than we expected, in the 6 to 8% range at baseline, and we were able to lower that by some small marginal difference, but the percentage differences were reduced overall, and overall 19% reduction in undiagnosed hypertension using this measure that we constructed for it. So I think we felt that we were having some impact there. And then finally, the ultimate outcome measure of hypertension control using the NQF-18 measure. You can see that our rates ranged from 50 to 70% at baseline, and we were able to increase them by over 10% in each case. So we were able to make an increase, which was the goal of the project, over the 10% goal that we had been set. So that was gratifying. And I think obviously a lot more room to go, though, however, because even 70 or 80% is not really where you want to be. So some of the lessons learned, and we'll talk more about this in the discussion, but the collaboration across the sectors was key. We couldn't have done it just with the FQHCs or just with the data people or just with the county health departments. So really getting people together, and this was really the first time in these counties and these communities, these groups had sat down together and actually talked about what they were doing in their common goals. So that part of it in and of itself was extremely valuable. The senior leadership involvement at all levels, and Paul mentioned that ASTO really made the health commissioners commit to several days at different points during this process of their direct active involvement, including attending meetings, which for our many health commissioners is difficult to commit to, but it worked. It worked, and yeah, he complained, but he did participate. So, and that was extremely helpful. And when, the State Health Department in New York is the Medicaid regulator, is the managed care regulator, when the state health commissioner calls up and says, we want you to come to a meeting, people generally come. So that level was definitely needed, and that high-level leadership was what set the stage for it to be successful. We've talked about in this meeting even about lessons learned around collaboration, but clear, consistent communication and really agreeing on what your goals are and your commonalities is critical and was critical here, and a lot of time was spent on that discussion, and I'll talk about some areas where we still are trying to figure out how to move forward in some areas, but at least the discussion is engaged now, and we're working on it. Can't say enough about the efficient use of patient registries, or even to have patient registries. Electronic health records are not a patient registry unless you can set them up and use them in that way. So there's still a lot of work to do in that area at this point, unfortunately. So in our project, the fact that we had a common EHR platform was critical because we could generate the data. If we had 3 different health centers with different systems, I think it would have been much more difficult to really have everybody looking at the same data and being sure that what we were measuring was what we were really interested in. We did find it was helpful to develop new metrics, and I think that's always something good to get your group engaged with, because then they feel invested in what you've come up with, and they believe the metric if they had a hand in doing it. So that we thought that was a helpful thing to do, although clearly you need to validate things before you go to large scale to be sure they're working. I think this was an occasion where our federally qualified health centers got together much more closely with their local public health departments than they had, and it was valuable to have a project like this that was sort of something of interest to the FQHC and from a clinical point of view, but also to the population health point of view that the local health department brought. So that just, again, sitting people down at the table around a common goal, I think has had lots of spin-off benefits since then. And amazingly enough, we were able to reduce, improve hypertension control in this very short time frame, which was the challenge. And I think it just is a credit to the ongoing nature of the work and the funding that ASTA provided to allow us to manage, and then the sites to actually have people dedicated to work on it. So that message there is, if you want this to work, you need to adequately fund it, so that because it is not part of everybody's other job. So just to talk a little bit, I've mentioned this, the role of public health at the state level. It was important to have the senior leadership engaged. We do have other resources at the state health department and our CDC grants that we were able to engage in this process. So the state health department really directed and was the convener. But also, as I'll show you in a minute, the state health department has a lot of other initiatives underway, and to align this work with and inform this work, like our SIM grant, was a critical part of this. As I mentioned, we are the Medicaid and managed care regulator and operator in the state, so that was helpful to have that connection. And we also have the access to the true population data for the state that we can put out there. The mantra is always evidence-based strategies from the state level, so that was helpful, and other aspects. At the local level, I think, as I mentioned, it was key to have the county health departments engaged in this, and they were members of the QI teams at the sites, and help to engage and connect people in the primary care and the FQHC world out into the community organizations that supported, for example, the home blood pressure monitoring aspect. So public health was definitely engaged in this at both state and local level, and was very helpful. So we did identify a number of opportunities for improvement, and I'll discuss a few of them quickly. One very specific example that we came up with is the problem of restricting prescriptions for medications for hypertension to just a 30-day supply. And this is not a Medicaid rule in New York, but it seems to be that most of the managed care plans do this, and the concern is cost. If you give a 90-day supply and then you change, then you've wasted a bunch of medicine. So this is an area of ongoing discussion. I think if you can get a patient on a stable regimen that's controlling them, that's the point at which if you could flip over to a 90-day supply, you do much better with adherence. And I think they're pretty good data to show that with 30-day supplies, you start to lose people because they just can't keep up with getting the prescription refilled at that slow level. But that's an area of ongoing discussion, I would say, to try and figure out what's the sweet spot there to pick it. So in other areas, I mentioned this idea of electronic communication when a prescription is refilled. That's something that you really need an electronic system that goes in both directions. So, for example, in the Medicaid program, we can tell when a prescription is filled in real time from our pharmacy claims system. But how do you get that data back to the provider to know that the prescription was actually filled? And so that's an area of ongoing effort. We do have a major initiative in New York to develop a statewide health information network. We call it the SHINY. And to connect regional health organizations like the Rio, I mentioned the Hicksney Rio in the Albany area, so that data can flow and go in both directions. And we're, I think, working towards, and we do already share Medicaid prescription data back to providers in some instances, but to really make that part of the system so that the physician or the provider in the clinic has full knowledge that yes, the patient filled the prescription, or no, the patient didn't fill the prescription. That might result in an earlier call out to the patient to find out what's going on or what went wrong. And there are other systems like that in New York when the managed care plan does get a notification when their patient shows up in the emergency department, but the clinician may not at this point. So to try to build in two-way communication, I think there are lots of opportunities in addition to just fixing EHR so they actually function as a patient management tool better as a registry function, I think are steps that can be improved. So in terms of where we're going now with this and the expansion of it, there are two different CDC grant programs that we're basically tapping to continue this work and expand it. We're going to, over the next couple years, expand to 9 federally qualified health centers, with 63 different sites. And we're going to also expand from just looking at hypertension to also diabetes control and pre-diabetes identification in that work. So we are continuing the work and expanding it with the same kind of a collaborative approach. And then with our other major CDC grant, we're looking to improve the data exchange between the RIOs and the FQHC network warehouse to try and overcome these EHR differences and improve the alerting and communication function. So we're actively engaged there. And then finally, we have a number of major initiatives going on in New York, which this work will inform as we're redesigning our healthcare system. The prevention agenda, and I think I'll just flip to the next slide to show it graphically, but our prevention agenda is our state health improvement plan that governs our public health work in the state. Just looking forward to the next session talking about hospitals. We have actually required our counties and hospitals to do their local public health plans jointly together and to work on at least 2 projects together. So hypertension is one of those areas where we hope that will be taken up. So that's our major driving plan within the public health world. We also, as people may be aware, have a major new Medicaid waiver, DSRIP waiver in New York, which we're just in the process of implementing. We're choosing now the 25 performing provider systems around the state, this is really a health system transformation process, but the goals built within the DSRIP are individual, are goals like hypertension control or population health goals like population hypertension prevalence. So the goals that we spelled out in the prevention agenda have carried over into the DSRIP application, and the work that we did on Million Hearts we hope will be picked up by some of the projects, and this is a $6.7 billion enterprise over the next 5 years. So this is actually real money happening here. We did apply and are now implementing a SIM grant in New York, and again we will be using the same measures, and hypertension being one of them. A very exciting aspect of this grant is that we're going to pay or for local public health detail workers in regions around the state to go into practices and talk about population health measures and public health measures and the kinds of lessons that we learned from our Million Hearts Collaborative. So this work will very directly carry over into other work within the department. And we have a fourth initiative around regional planning, which also this will feed into. So the Million Hearts really came around at the right time. All these initiatives are just getting off the ground, so we were in on the ground floor to really align, that word again, align what we're doing here across all of the, what I'm showing you here is all of what the major initiatives of this New York State Health Department right now in the whole area of improving health and health systems transformation. So I just wanted to acknowledge lots of people worked on this, both within the health department, but also, and we didn't list the names at the local areas that would go on for several slides, but really to make the point that this was a true collaboration and lots of people were involved. And I included a slide if you want more information, people can contact. So thank you very much.